Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. IVIG, Intravenous Immunoglobulins, is a sterile solution of predominantly IgG antibodies, which are in the levels of supraphysiological levels. If it is a drug, we will call it as suprapharmacological levels, which we will give in DCP pulse. Here, from where we will get this supraphysiological levels of IgG antibodies. They are extracted from purified human plasma pool. Pool means donated by many healthy individuals. More than 1k healthy individuals pooled plasma. From there we will get IgG antibodies mainly. All the rest of the trace amounts of IgG will be eliminated from that IVIG solution. Try to donate your blood at least once a year. It will only enhance your health. It won't do any harm. If you do good, it will come to you one day. But that one day will come very late. It may take sometimes a lifetime also. Ideal IVIG should be sugar free with low sodium and should be at physiological osmolarity without causing any hyperviscosity and thromboembolic events. It should be at physiological osmolarity with sugar free and low sodium. Coming to mechanism of action, it inhibits the production of pathogenic antibodies and it will also neutralize the pathogenic antibodies. It will reduce the half-life of circulating antibodies. So it is stopping production of antibodies. It is reducing the half-life of already existing antibodies. It also inhibits autoantibody mediated cellular activation, autoreactive T lymphocytes. It reduces the keratinocyte apoptosis by disrupting Fas ligand and its receptor interaction. So it is saving the keratinocytes from apoptosis also. If we combine steroids with IVIG, they both will act synergically and suppress lymphocytes activation. This is systemic steroids. If we give topical steroids along with calcipotriol, they both also will act synergistically. Intravenous immunoglobulins is used when conventional therapy failed. First itself we won't go for IVIG. First we will keep conventional therapy. If it fails or use of high dose long-term steroids or any other immunosuppressant agents are contraindicated, then as a last resort we will use IVIG because it is very costly. Uses, FDA approved uses. FDA approved use, only one use, Kawasaki disease. Off-label uses, autoimmune bullous diseases like pemphigus vulgaris, foliaceous bullous, pemphigoid, cicatricial, pemphigoid, SJS and 10. Autoimmune connective tissue diseases like scleroderma, dermatomyositis, SLE. Autoimmune urticaria, as our IVIG will control effectively autoantibodies. Atopic dermatitis, graft versus host disease, infections like staphylococcal toxic shock syndrome. Coming to pre-treatment evaluation, serum levels of IgA. If a person has very less amount of IgA, if we give IVIG, if in case it contains IgA, it will lead to increased risk of anaphylaxis. So, if a person is having very good amount of IgA, he will be best suited for IVIG. CBC, LFT, RFT and weight of the patient. This weight of the patient is to monitor the fluid overload. We are giving continuously infusing large amounts of IVIG. It may lead to fluid overload that we can see by increasing in weight of the patient. Screening for viral markers, hepatitis B, C, HIV. This is to tackle any medico-legal cases, if at all arises. Screening for rheumatoid factor and cryoglobulins. If there is any cryoglobulinemia, it will increase the risk of thromboembolic events. That means formation of thrombus in heart, brain, myocardial infarct, cerebral infarcts. Coming to administration, how we will administer IVIG. Recommended dosage 1 to 2 kg. How we will deliver this dose? Usually delivered as a consecutive daily for 5 days or daily for 3 days. A dose of 400 mg per kg per day. As slow IV infusion over 4 to 4.5 hours. With careful monitoring of heart rate, BP, slowly we will infuse this IVIG. IVIG's T-half is about 3 to 5 weeks, that is almost a month. So we will administer this cycle monthly once. Either you can choose a 5-day cycle or 3-day cycle with 400 mg per kg per day. Coming to contraindications, absolute contraindication is history of anaphylaxis to previous infusion. This is not infection, infusion. Relative contraindications are congestive heart failure, renal failure, which will increase the risk of fluid overload. This is the adverse effect of IVIG, that is risk of fluid overload and risk of anaphylaxis. If a patient has IgA deficiency or anti-IgA antibodies, rheumatoid arthritis, he will be more prone to increased risk of anaphylaxis. What and all will be there in anaphylaxis? We all know. Cryoglobulinemia. As I already told you, it increases the risk of thromboembolic events. This thromboembolic event mainly happens because of hyperviscosity. So, to reduce the viscosity, what we can do? We can give prior IV fluids. And to prevent thrombus formation, what we can give? Prior anticoagulants. Coming to adverse effects, already we have seen 3 adverse effects. One is fluid overload, one is anaphylaxis, one is thromboembolic events. So, prior hydration is very important. Acute renal failure. In anaphylaxis, there will be headache, chest pain, chills, fever. So, we can pre-medicate the patient with paracetamol, and while infusion also we can give steroids. Acute renal failure can occur due to osmotic nephrosis if IVIG contains sucrose. That's why an ideal IVIG, what it should be? It should be sugar-free with low sodium. If it contains sugar, that is sucrose, what will happen? Osmotic nephrosis, which may lead to acute renal failure. Transient neutropenia, name itself suggesting it will resolve on its own. Rarely hemolysis, as we are transfusing some others plasma, immunoglobulins, there may occur hemolysis because if the patient is having any antibodies against blood group antigens. That's why we will purify the solution. Remember the channel name. Don't forget to like, share and subscribe. Thank you. Hasta la vista. Das vidaniya.